Yes, doctor.
Can you
Hello.
hear me?
Yes, Dr. Amal, welcome. I introduce you, but you
Yes,
didn't
I'm
listen me.
sorry. I'm so sorry
Again,
I
my
had the
colleague.
technical issue. I'm driving, and thank you for your introduction. I'm not going to keep you. I just want to say that I'm so proud of you on the personal
Thank you,
level,
thank
on
you.
the professional level. And I wish everybody very good luck. And you have the best teacher you can ever have. So good luck to everybody. And again, I'm really, really proud of you, Dr. Rami, and I'm learning from you now. Thank you.
Thank you. No, 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 thank you. By the way, my colleague Dr. Amal is a big consultant in Egypt. She learned a lot of generation. Um, I was one of the third generation for her disability. So thank you, Dr. Amal, for your attendance. Really, it is humbled situation from you. Thank you so much.
I'm honored.
Our
Thank you. I'm honored.
Thank you. Welcome, Dr. Ahmed. Next candidate, 90-year-old female patient
And
with right groin pain. 90 year
oh,
old. 1 second, 1 second,
okay,
1 second. 90-year-old female patient with right groin pain. Go on, doctor.
okay. I've been provided with frontal radiograph of mature skeletal patient of 90 years old, female. Uh, Sorry, sir, can you? Okay. Of 90 years old female coming with bright groin pain. I can see that there is evidence of widening of the right femur, especially involving the proximal part of the shaft and extending to the greater trochanter. There is
Okay.
evidence of widening and there is evidence of thickening of the cortex noted within this part. Also, I can see that there is evidence of abnormal medullary ecogenicity noted
Doctor,
within this part.
doctor,
Sorry.
doctor, why
Yes.
you are opening this list?
I am not the one. I'm not the one who's
Leave the
moving
mouse.
the.
Okay. 1 second.
I thought you are the one, doctor, who's opening this.
No, some ghost in between.
Okay.
Go on.
Okay. I can also see that there is evidence of rather than widening of the bone, thickening of the cortex, and there is abnormal trabeculations noted. I can see also that there is abnormal translucency noted within the medial aspect of the cortex of the proximal femur, suggesting that there is evidence of pathological fracture may be noted within it. My provisional diagnosis for this could be Paget disease involving the right femur. I want if I want to compare this X-ray with the previous. Also, I want to check the alkaline phosphatase enzyme. I would convey this finding for the orthopedic doctor, and I would also recommend for nuclear medicine to check if there is
What is
any
your next step? What is your next
uh,
step?
uh, I would go for nuclear medicine, PET-CT, to check if there is any multiple polycytic Paget.
I,
And also, if I am suspecting that there is evidence of any malignant transformation for osteosarcoma, I would go for MRI first, and after this, I would go for PET-CT.
doctor, are you sure you will go to MRI and alkaline phosphatase? This is your next step. Are you sure?
I said I would go for a PET-CT first to check if
What
there is
about
any
the other
polycytic.
orthogonal views, doctor?
Oh,
Why?
sorry.
What,
Sorry.
what
Okay.
was? Go on.
Okay.
Yeah.
The okay. I can see that there is evidence of this is the other orthogonal view. It appears to be the same uh, image. However, I can see. This is appear to be long lesion within the upper. It's not involving too much of the cortex, sorry, of the femur. And also, again, it confirms that there is maybe a fracture noted within the medial cortex. uh, as this patient is 90 years old, I'm thinking of another differential diagnosis for this, like fibrous dysplasia, but it appears to be with 90 years old.
What is your next step?
I, uh, mm, I can go for CT.
And what about this orthogonal? Doctor, you see
Okay.
it, you must request. Look here, you will see something here, and this is the key. What is this?
Sorry, Doc, this is periosteal reaction noted, maybe. I'm not,
Okay.
yes, there is a fine periosteal reaction, so it could be also MITS. This could be MITS or multiple myeloma involving this part of the bone with this fine periosteal reaction. I want to go for, after this, maybe MRI.
Yes, yes. But see, our colleagues, very important in X-ray to ask for other orthogonal views. Why? Doctor, you change your mind more than 180 degree, 180
Yes,
degree, from a benign to malignant, from this
yes,
orthogonal, because there are periosteal reaction very
yes.
obvious here. And
Okay.
what about the lesion itself here? Is it ill-defined,
Uh,
wide zone of
it appears to
transition?
Yes, it appear this lesion it appear to be wide zone of transition, especially in
Okay,
its
what
upper border.
else? You don't need to talk about
With this,
extra-osseous
yes, with this,
region.
okay, there is maybe some soft tissue component I can see with widening of
Okay,
uh,
this is our,
displacement of the.
okay,
Okay.
this is CT. What happened here?
Okay, in the CT, I can see it confirms the pathological fractures that noted, and it appear to be ground glass opacity involving the right upper femur. Um, Also, I couldn't see that there is evidence of soft tissue component. Um, okay, but
What is
sorry,
your
Doc, but
next?
I want to
Your
look for the axial view to be sure about this periosteal reaction. I want to look for the axial view. Can I look for the axial view?
look here.
Okay, but in the axial view, okay, there is no evidence of periosteal reaction.
But there are
Um,
some radiation here. This is what we see.
this is the pathological fracture. This is the fracture that we
Yeah,
noted already.
yeah,
But
and see
it's
here.
not periosteal reaction. Yes.
Yes, yes, but
Hmm.
see what we see
Hmm.
in the lateral or in the lateral. See this
Hmm.
one. Is this related
Oh,
to aggressive nature or not?
yes. Yes. It's
Irregularity.
related.
See, irregularity.
Yes.
Okay. What is your next
Hmm.
step?
Okay, I want to look for MRI.
Okay. No MRI. See, doctor, please go
MRI.
to the matrix and tell me what is the matrix here. You told me it
Uh,
may be melanoma metastasis and what else?
Fibrous. It could be fibrous dysplasia. It appears to be ground glass.
What is this, doctor?
However, I can see this evidence of calcification
So,
noted within it.
yes, so
It could be chondroid matrix, chondrosarcoma.
excellent. Chondroid matrix plus aggressive nature or non-aggressive.
Uh, it would be aggressive nature with this in the axial view, this abnormality in the cortex. It could be aggressive nature.
Sure, aggressive nature or you are in doubt. Look here. What
Uh,
happened here? What happened here?
yes, there is thinning
Hmm?
of the cortex
Thinning only or some erosion. Look
with
here.
a mild disruption. Yes, with mild
Yeah.
disruption of the cortex.
So this is aggressive or non-aggressive.
So it's aggressive.
Aggressive. What's your final diagnosis?
It's an aggressive lesion involving the proximal femur with pathological fracture and periosteal reaction. It shows calcification within, which could be chondrosarcoma. This would be my first diagnosis. It could be chondrosarcoma. Second, it could be with the thickening of the cortex. It could be Paget with malignant transformation of
Thank you, doctor.
chondrosarcoma.
What happened? Thank you, doctor, so much. What happened here, my colleague? Really, from the first look, it looks like budget, frankly speaking. But when you follow the proper procedure, you will change your mind one by one. Look here. Oh, the lesion. There are lytic lesion, not just lucency. And this lytic lesion cause erosion, at least in the endosteum. Erosion of the inner part of the already thickened cortex. But there are no other signs of Paget here, by the way, apart from thickened cortex. Okay, my colleague? And what else? When you see this one, you feel there are something here. Despite it is not in CT actual periosteal reaction, but you have some suspicion about malignant or aggressive nature. As long as you are running in the correct pathway, the examiner will not talk with you about something wrong in X-ray, but you are still in the correct pathway. Here, very important to look well to the matrix. Look, very few calcification, one or two, change all our diagnosis. Second, only just small pieces of destruction, small, very small. Okay, it is make us on the sure pathway of malignancy, despite in this age group, um, the most common malignancy here are metastasis and myeloma, but it is finally in 90-year-old female patient, it was a chondrosarcoma. Thank you, doctor, so much. This is the style of exam, my colleague, either in Arabic board, in FRCR, or in any Egyptian MD, anything. They love to bring an a typical case, okay, in sorry, a typical pathology in a typical location. They love it so much. And by the way, this is their right because they examine us at a very high level. They are examining us at it is very critical level. So they will do everything. Test candidate, Dr. Mariam, I may take
Yes,
another.
candidate 6. Yes,
Yes,
where
I
is
am good.
candidate 6?
Please
Okay.
prepare. I will take up to 8 candidate. Okay. I prepare another cases. This case I will finish. Okay. Doctor, this 85-year-old female patient presented with abdominal pain and diarrhea and nausea. Take care from this case, please. Can you request control, please? Hello?
Yes, sir, I hear you. I requested control.
Yeah, go on.
Sir, I cannot scroll it.
No, it is scrollable here.
Okay. I am provided post-contrast images of abdomen of a patient with history of nausea and diarrhea.
Yes.
Sir, it is not scrolling from my side. Can you scroll for me?
Leave the mouse, leave. Leave.
So I can during scrolling I can appreciate
that there is few calculi in the visualized wall bladder lumen. I can, it is jumping. I can also appreciate mild pelvic ascites. Yes. The, so it is jumping.
Here,
Yes. Sir, I can appreciate, yes, I can appreciate there is mild ascites along the right border of the liver, which is causing scalloping of the liver. Uh,
no scalloping.
yes,
This is the diaphragm, indentation of diaphragm. What else?
okay,
I
okay.
think this is indentation of diaphragm. Look here. What else?
Sir, I was unable to.
What else?
Sir,
If you couldn't pick
I
up
think so.
any
There is,
abnormality,
yes,
what will you do?
I, sir, because of the history, I was looking in the right lower abdomen uh, to look for
Mm-hmm.
I can appreciate there is mild thickening of the descending colon and part of the cecum. I want to
Yes,
look at the appendix.
look at the appendix.
Yes, there is a dilatation of the appendix as well as there is enhancement of the wall of the appendix. There is some free fluid around the appendix as well as adjacent to the cecum. I cannot appreciate any size significant mass lesion in this location. However, there is thickening of the cecum as well as the appendix with the mild fluid in the right iliac fossa, more so around the appendix. Uh, I cannot
Yes.
appreciate any lesion in the liver. I cannot appreciate any enlarged lymph node. So, keeping in view these imaging finding, I am thinking of a neoplastic etiology involving appendix as well as cecum.
Yes. Where exactly?
So it was appreciable on coronal because in Excel the images are jumping. I cannot appreciate it.
Could you see anything in the axial?
There is no enlarged lymph node or size significant mass, only thickened
About this?
enhancing wall of the appendix.
PC. What about this?
Yes,
This
yes, yes. There is a rounded soft tissue mass lesion involving the distal small bowel loops in the anterior part of the
if
anterior
I
part
told
of
you
the
this, this is the same part
sorry.
that you pick up here. So where is the malignancy?
So that was cecum. So sir, my
Mhm.
different at this point my differential would be adenocarcinoma of the cecum uh, with no significant lymphadenopathy or adjacent structures invasion, or other differential would be adenocarcinoma of the appendix with the extension into cecum.
Okay.
I would convey my findings to referring physician and refer this patient in gastroenterology MDT for biopsy, further staging and management.
Brilliant, doctor. Really, really, it was the most difficult, the case of today. Thank you, doctor. Really, you have very, very good eye. Look, my colleague, what happened? She looked at the exam and she didn't pick up any obvious abnormality. And the patient has a clinical complaint and he is old age, he or she. So our colleague did very, very important thing. She looked at the appendix. In all abdominal cases, either acute, acute or chronic, old or young age appendix. Look at the appendix. See here, if look, this is at the base of the appendix, or it is, look here, where is the appendix? This is the appendix. It is dilated by the wheel and mural enhanced. Look here, the base of the appendix, يعني it involving the base of appendix and cecum. What happened here? This is not ileocecal valve, by the way. How could we differentiate? Follow the terminal ileum. Okay, my colleague, follow the terminal ileum. It will be very clear in axial. Okay, my colleague, how could we follow? This is the ascending colon. Go down, 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 down again. Okay, down, down. What happened? Here, the lesion from posterior. This is the ileocecal junction, anteriorly. See, my colleague? Here, in many sessions, I told you that the appendix is just lateral and posterior to the ileocecal junction. And the ileocecal junction may have some fat. But here, because we have a tumor here, the anatomy is disturbed. At least if you told the examiner in this location there are malignancy, it is, for example, maybe the cecum, almost the cecum. He will be very happy. Okay, and if you want to add more markers to your sheet, look at in the coronal, try to look at the appendix. Really, appendix is very difficult in this case to be picked up in the axial, but here, look here, light ended, follow it, follow, surrounded by fluid. Another tip or another يعني experience. Look here at this exam, you will not find other than the pelvic ascites or fluid. That is what our candidate do. What she did, she looked the only abnormality here, pelvic pathology, so she looked very well to the surrounding structure and defined the appendix and pick up the adenocarcinoma. Really very, very fantastic, doctor. Thank you so much. Thank you, doctor. Next candidate.
Yes, sir.
Okay. Look at these two cases. It is very nice cases. Two very nice cases from GIT. Are you ready?
Yes.
35-year-old female patient complaining of abdominal pain. Request control if you want.
Okay, I'm requesting. I have requested.
Go on.
Okay. Yes. This is the MRI abdomen. Coronal section star images in which I can appreciate. I will go through the whole stack of images.
What is the name of this sequence?
This is a coronal image with this is a heavily T2 weighted image.
Okay, excellent. And
Yes,
why this is heavily T2?
because
Why?
it is showing the intrahepatic biliary channels and the fluid containing structures.
So you can consider it as MRCP.
As MRCP. Yes, yes.
Okay, it is better to start with this. It is very more easier. Go on. Yeah, scroll.
Okay. Yes, I will scroll. So it's 1 second. I will click it again. Yes, now it is scrolling. The first the abnormality that I can see is that there is a T2 hyperintense lesion that is seen just adjacent to the right lobe of the liver. It is showing internal hypointensities. There is mild intrahepatic biliary dilatation noted. I will trace the origin of this lesion. Sorry, it's jumping. So both adrenals and the kidneys are unremarkable. So this is an intraperitoneal in location. I am trying to see the gallbladder. The gallbladder is separately visualized from the lesion. The portal vein and the hepatic vessels are compressed by this lesion.
So, what is your suggestion?
Can I see the axial?
Zigzags.
Okay. I will, I'm seeing the pancreas to see any relation of the lesion with the head of pancreas.
Mm-hmm.
Sorry, the scroll is a bit lagging. So the body and the tail of pancreas is unremarkable. There is no significant pancreatic duct dilatation. There is the pancreatic head is not clearly visualized and appears to be compressed by the lesion. There is I'm trying to see the common bile duct. This appears to be continuous with the intrahepatic biliary channels. My possibilities here are some lesion related to the common bile ducts, or it can be other differential possibility that I'm thinking about is the choledochal cyst. But there is a intralesional hypointense signal seen. I would
Mm-hmm.
like to see the diffusion restriction.
Okay, this is the diffusion.
Yes, the part of the lesion, the intralesional area, it is showing hyperintense signals on DWI. I will check on the ADC to see the restriction.
This is ADC.
Yes,
Mm.
in the ADC, no, there is no restriction.
Sure. This
So,
is
because
the ADC.
this, yes, this area was, yes, there is restriction. There is restriction. Low ADC, the same area was high on DWI and low on ADC. So the part of the lesion that is within the cystic area is showing the diffusion restriction. So this
So,
could be
what's
a primary lesion
your
of the common bile duct.
what?
The lesion, the lesion involving the common bile duct.
What is the name of this sequence
The-
or this
This is
image?
the 3D sequence for MRCP.
Excellent. Give me a
It
final
is showing
diagnosis.
it is showing a dilated extrahepatic common bile duct as well as intrahepatic biliary dilatation. The pancreatic duct is not dilated.
So,
There
give
is
me a final diagnosis, please. Mm-hmm.
final diagnosis is common bile duct, there is could be common bile duct no, it could be choledochal cyst.
Yes, with what is this?
Choledochal cyst.
What is this solid component?
The enhancing solid component, yes, it looks like neoplastic.
Yes, so give me a final diagnosis. Trust in yourself. You are
Yes,
correct.
yes, it can be choledochal cyst with associated cholangiocarcinoma.
Excellent. Please, my colleague, trust in what your eyes are seeing inside the exam. Some cases, at least one of the viva must be something like this: colorectal cyst, okay, with malignancy, adenocarcinoma. Okay, how can we differentiate between colorectal cyst, our doctor, and obstruction down here? Why is this not a CBD obstruction causing this market dilatation? Hello?
Yes, because there is for the CBD obstruction, there should be an abrupt termination of the distal part. I cannot see.
Okay. There are no here, if you look here, there are no any mechanical obstruction.
Right.
If
No
you look,
pancreatic duct dilatation as well.
see,
Yes.
here, there are no any mechanical obstruction. So keep this rule in your mind, my colleague. Dilated CBD without mechanical, either internal or external, or even mural obstruction equal colorectal cyst. Equal immediately. Okay? And it will be not a usual dilatation. It should be capacious dilatation like this. So our final diagnosis here is a colorectal cyst with carcinomatous changes or adenocarcinoma. Could you enumerate the different type of colorectal cyst?
Choledochal cyst, there are 5 types of choledochal cyst.
Mm-hmm.
The type 1 is the extrahepatic. Type 2 is diverticulum of the CBD.
Mm-hmm.
Um, type 3, type 5 is Caroli's. Type 4 is both intra and extrahepatic biliary dilatation. And type
Mm-hmm.
3, sorry, type 3 I
Okay,
forgot.
doctor, this is more than enough. At least type 5 is Crowley. Okay,
Caroli's, yes.
type 4 is intra and extrahepatic. At least
Yes.
يعني you can keep in mind like this. Type 5 is Crowley, all of us know it. Type 4 is intra and extrahepatic. Type 1, 2, 3, all are extrahepatic. Either eccentric or fusiform like this, or um, mucosal or colloidal cell.
Choledochal
Colloidal
cyst,
cell.
yes.
Okay, thank you,
Yes.
doctor, so much. Next
Thanks.
candidate.
Assalamu alaikum.
Alaikum assalam. Doctor, could you request control?
I'm unable to request control. Can you please scroll for me?
Yes.
Thank you.
75-year-old female patient with history of abdominal pain. What happened
Okay,
here?
I am presented with the post IV contrast axial CT scan images in the arterial phase. First, I would like to see whole of the images, and then I will start commenting. Till now, I can see that the liver is cirrhotic in appearance.
Okay. Why I split the screen? Because in liver must work by comparison. Very important. Even if you only told the examiner, he will be very happy. Mm-hmm.
Okay, so there is a small calculus in the dependent part of the gallbladder. I could also see another exophatic lesion in the right lobe of liver, which was
Excellent.
showing enhancement on arterial
Which
phase.
one? Which one?
For this one.
Okay.
From right lobe segment 6 of the liver, partially exophatic arterial phase enhancing lesion. I would also want to see this lesion on the venous and delayed phase images to characterize this lesion further.
Okay. See, this is arterial. This is venous. Tell me what happened. Mm.
Uh, this is not showing any significant washout. I would also want to see the delayed phase image to further delineate this lesion. So on delayed phase, this does show some washout. Considering the enhancement on arterial phase and washout on delayed phase, and considering the cirrhotic liver morphology, this is concerning for hepatocellular carcinoma. However, I would correlate with patients' alpha fetoprotein levels as well. I would, in my routine practice, I would see rest of the images of the chest, abdomen, and pelvis to see any additional lesions,
Brilliant. Doctor,
metastasis.
could you go in depth in this lesion description, please? Why are you sure this is HCC? And if you are sure, which lyrate, if you know, can you give to it? Can you classify it?
No, actually, this is showing more of a peripheral washout rather than central washout. Um, I'm not sure about the Lariat's classification of this, but I'm sure that it is a hepatocellular carcinoma.
Mm-hmm. Okay, doctor. What else?
Mm, in my routine
Else?
practice, I would also see the bone wind images to comment on
Could
the.
you detect any lesion, doctor? Could you detect any lesion here?
Yes, there is another lesion adjacent to the IVC, which is also partially exophatic in nature.
Mm-hmm. So,
This lesion, yes, so this is likely a multifocal type of HCC,
mm-hmm.
but this lesion
Yes.
I think does not. Yes,
What happened for this lesion? Describe.
this I would like to see this lesion on the coronal images as well to see that this lesion is arising from the right adrenal gland or from the liver parenchyma to confirm that it is a metastasis or a hepatic lesion.
This is a delayed. Look. Mm.
Yes,
What do you
so
think of this lesion?
undelayed phase image, it remains hyperdense. In my routine practice, I would take its washout by calculating its relatively and absolute washout to comment on the nature of this lesion.
One
If
junior,
this lesion,
one junior, one junior registrar in your department suggested to you to take a biopsy because the lesion is inseparable from the liver. It is okay. You are okay with him. It is centered in the right suprarenal, but he noticed that the lesion is looks like infiltrating or inseparable from the liver. You are the consultant. What is your opinion?
in my opinion, I would, as the center of the lesion is likely in the adrenal gland, I would calculate its relative and absolute washout. If the relative washout is more than 60%, it would be more in favor of benign lesion like adenoma. If the washout is less than 60%, then can recommend a biopsy of this lesion.
Okay. So you are may recommend, at least may recommend biopsy. Look here, doctor. What happened?
Um, So on these MRI arterial phase images, paired saturated images, the lesion confirms to be inside the liver parenchyma and is partially exophytic and involving the right adrenal gland.
Are you sure?
Yes, no, I'm
Should
sure
biopsy
that it is in.
this lesion or not?
This lesion is also communicating with the right branch of the portal vein, and is I'm trying to figure out that if this lesion is also communicating with the IVC to rule out a shunt. I think there
So,
is a
what is the
shunting of the.
most probable diagnosis for this lesion?
So this is likely a venous type of shunt. With probable malformation, or it could be a HCC with venous shunting.
If I told you this is cirrhotic lesion, this is cirrhotic patient, what type of connection between the portal and the systemic, either IVC or branch from it or a draining vein for the adrenal? What is the name of this connection, doctor?
Mm,
Between the portal
um,
and the systemic venous connection, abnormal
photosystemic shunting.
varices.
Varices,
Okay?
okay.
Thank you, doctor. Don't
Uh,
biopsy this patient at all.
okay.
Okay, don't worry. It is very difficult case, but really very interesting. Thank you, doctor.
Very
You did very
interesting.
well. You
Very
did very well.
interesting
Take
case.
care.
Thank you.
Welcome. My colleague, take care from the liver in Lyrate. Even you don't know the Lyrate, but at least the basics. I told before some basics about Lyrate. See, we look at the arterial. What happened? This is cirrhotic. Okay, all of you know how to differentiate irregular border, hypertrophy of the caudate, and there are a ratio between the caudate and the transverse diameter of right lobe. It should be not normally not more than 0.65, but here it must increase. And your main task to pick up any observation, any abnormality in the liver in the dynamic studies called, you can call at the beginning observation, because you don't know. It may be no, THAD, which mean abnormal يعني THAD means transient hepatic enhancement difference, which norm, not a tumoral tissue, or maybe regeneration nodule, or HCC, a very wide variety of pathology in cirrhotic liver. Our colleague pick up this lesion very well in the arterial. So I helped him and I do split the window. You must ask the examiner, doctor, I want to see or to see portal arterial and for example delayed or venous in a splitted window. Okay, he will know that you are very good radiologist. Okay, what happened here? This is the arterial. It show this is the lesion. Lesion has mainly central hyper enhancement, which called APHE, 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 arterial non-peripheral hyper enhancement. Central should be central. Central here is more enhanced than the peripheral. Arterial non-peripheral hyper should be hyper enhancement more than the parenchyma. Compare it with the venous or with the portal, sorry, with the delayed. See, this is, I think this is the venous. No obvious washout, despite there are some, by the way, here some washout. But if you look here at the delayed, it's very obvious central washout. Also, the washout should be, see, what is the meaning of washout? Washout means to be less enhanced than the liver. Hyper enhancement means hyper enhanced than the liver. Okay? So we transformed from hyper enhancement to hypo enhanced in comparison to the liver parenchyma. This is the typical signs of HCC. Okay, my colleagues, this lesion, because it is big, it is about more than 2 cm, 2 centimeter, it is a lyrate 5, the highest of lyrate. This means this is typical HCC. Okay? In the lyrate, there are main criteria. Number one, arterial hyperenhancement, and central, it should be central. Also, central washout and capsule. There are here no obvious capsule, by the way, and something called three-shot growth. What is three-shot growth? This is means if you follow the patient within 6 months, less than 6 months, 6 months, the lesion size will increase by 50% at least. This is the major four criteria. There are one table for lyrates. At least you should retain and keep and remember the main signs. It is very important. But this is not the disaster of this X-ray, this CT. The disaster is here. Look here. Really, it is very obvious adrenal lesion abutting or infiltrating the liver. No doubt. Here, no doubt. But if you look here, my colleague, see, if you look at the venous phase, you will see something strange. What is this? It is curvilinear blood channel, at least connected to the right posterior portal vein. Very critical. Okay? So tell yourself, at least this is vascular malformation. At least. So it should not be biopsied at all. This is fatal mistake. Okay? After that, the radiology consultant wanted to confirm his diagnosis, so he was intelligent enough and asked for MRI. MRI is very superior for soft tissue characterization. Look here, my colleague, even from the first sequence. Look here. This is arterial, not obvious. If we look here, look. Very obvious. Varices. Porto adrenal vein varices portosystemic joint. Very dangerous to be biopsied. This is after 7 years, by the way, but this is available MRI, complementary MRI for this patient. So this lesion is post-tase, by the way, post-tase, okay? Take care from cirrhotic patient because they have a long run follow-up. At least here we pick up this very interesting sign. Okay, my colleague, I have a question. I finish my today session, but I have very important question. Why in the abdominal MRI we can see, I will, if here, ingredient, my colleague, you can see arterial aortic enhancement. Anyone know? Anyone know why? Again, the question, you do an abdominal MRI. Okay, my colleague, and you see in the gradient phase, the aorta is markedly enhanced. Why? If anyone know, please unmute yourself. This is very important. Anyone know? Which should be here? Ingredient. No gradient here. Anyone? There are something called inflow sign or phenomena. What happened? 1 second. What happened during the gradient echo? The magnetization of the aorta is in the same direction of the magnetic field. Okay, my colleague, listen to me or hear me or not? Hello,
Sir, the voice is breaking.
could you listen me now?
Yes, now it's better. Yes.
I'm talking about why in abdominal MRI, I'm trying to bring one gradient abdominal MRI. In gradient, it is for me even for me. I'm sometimes confused. Is this arterial post contrast or gradient? Why in gradient we sometimes see aortic enhancement? This is the question. Okay, I will. Anyone know? Even in brain, sometimes you see in gradient.
The
Okay,
voice is not clear again.
again, again. Why in MRI gradient the aorta is enhanced? Is my question clear now? Dr. Mariam, my question clear?
Yes, yes, yes. Sorry, the voice was breaking. Now it is fine.
Okay, because in gradient there are something called inflow sign. What is inflow sign? Ingredient, the machine or the sequence suppress most of the tissue except the flowing aorta. Okay? Okay, so the flowing aorta have active or unsaturated magnetization. So, or unsaturated. The rest of the tissue is saturated. So finally, the aorta is enhanced, and the other tissue are of dark signal. This is called inflow sign. There are other causes, but this is the most common cause because the spin of the flowing blood is more unsaturated. What is mean by more unsaturated? Not inhibited. It can give signal. Okay, my colleagues, this is very important. Ingredient, you will see the aorta enhanced like arterial enhancement. Don't confuse. How could you be sure this is not enhancement? Either to look to the surrounding tissue. There are no any contrast uptake in solid organ. Look at the branches for other branches. And third point, third point look at the image of gradient. It is totally different from T1 fat cell. In next session, I will show you one. Okay, my colleague. Thank you for attendance. The session is recorded and I will upload it within 1 or 2 hours. Thank you. Thank you, Dr.
Thank you.
Mariam, so much. Thank you, Dr. Omer.